everyone, and welcome to our session on the topic of laparoscopy for infertility. We are pleased to have Dr. Nupur Sood among us to educate us on this topic. She will guide us on this approach about diagnosis and treatment of infertility. So, Doctor, you have the stage.
Thank you. So, good afternoon, friends. I think all of us are seeing this very steep rise in the number of couples who are reaching to us now on the outpatient with trouble conceiving. And it's not necessary that, they are all just like about 35 years plus or with some major problems. Many of them are young couples also who come to us. So the concern is very serious in that ways because of the numbers who are coming in and the requirement for advanced treatments to help them conceive. What was something very natural has taken a very different route now. And even before some of the couples have to land up taking an IVF procedure or any advanced fertility procedure, and laparoscopy becomes a very, very important, like a bypass, because beyond that, if you don't cross that step, you cannot go into the next stage. So that's where we come into the helping situation. Now, I'll just briefly let you know what we exactly do so that anytime you need to go through it, at least you have a little more clarity as to what the procedure is all about. Now, all of you all have heard about laparoscopy, right? So, in general surgery, it's been there for years together. So, laparoscopy is done, you must have heard, for appendix, that's called laparoscopic appendicectomy. When the gallbladder is removed, it's called laparoscopic cholecystectomy. So, that's common procedures you must have heard in your household, among your friends circle, family. In gynecology, we use laparoscopy for uterus removal surgeries like laparoscopic hysterectomy or fibroids or ovarian cysts. So that's called as laparoscopic myomectomy. And also, you can hear about laparoscopic ovarian cystectomy. Now, when we're talking for fertility, what is the concern? So, if the woman is, so when we're trying a couple for helping conceive, there is a male factor and a female factor involved. And the female factor specifically, if is requiring laparoscopy, we are looking at it in a very anatomical way. So we are looking at the uterus, we are looking at the fallopian tube and at the ovary. Now, within the womb itself, within the uterus, there could be fibroids, which are small muscle overgrowths. They are not cancerous, but they can grow very huge and prevent pregnancy from happening. They can go right into the womb also, called submucous fibroids, which need removal. Then there could be abnormal uterus itself. That is, it could be too enlarged in case of an adenomyosis, when that has to be removed. And then there may be a septum. So the womb is supposed to be a hollow organ inside. But if there's something called like a septum there, curtain, that has to be removed. Otherwise, there's no space for the baby to grow. So that's called as a hysteroscopic procedure. So when we do any procedure from below, from below through the vagina, when we place the scope and we do a surgery, that's called as hysteroscopy. So laparoscopy is when we take two tiny keyholes and one umbilical port, and we do the laparoscopy from top. When we do from below, it's called as hysteroscopy. So it's commonly even done for people who have bleeding issues to check and to do a biopsy. But particularly here today, we are talking about fertility procedures. So for fertility procedures, we are doing like a septum removal, a submucous fibroid removal, polyp removal, or if we are just doing what we call as a diagnostic hysteroscopy just prior to doing a IVF procedure, because the final implantation is within the womb. So if there is any problem there, we shouldn't miss it. So there is even an endometrial scratching sometimes done prior to an IVF procedure, and if needed, even a biopsy is taken, endometrial biopsy prior to any of the advanced fertility procedures to rule out tuberculosis. And then again, we do the hysteroscopy. These are the various surgeries which are done within the uterus. Now, when we're going in for a laparoscopy, say a couple is not able to figure out why they're having difficulty in conceiving. That's where the trouble starts, because you don't know which way you're headed. And that's when the laparoscopy is going to guide you. So we do a diagnostic hysteroscopy initially. Then we go in through the keyholes, tiny 2 to 3 incisions. And then we go and assess the fallopian tubes. Now these fallopian tubes, we place a methylene blue dye and look for the spillage. The same thing which can be done on an HSG procedure. So those who have undergoing fertility procedures may be familiar or may have undergone this procedure called as HSG. Now, HSG is this minor X-ray radiation exposure where you need to lie down and the dye is pushed and you look for the spill of the dye and try to assess whether the tubes are blocked or not. Now, what's the advantage of then doing a laparoscopy? If you're doing a laparoscopy, we are not only checking the tubes, but then if they're blocked, we can open them also. So we call it tubal cannulation procedure. So a blocked fallopian tube can be opened. Then sometimes there is a condition called as endometriosis. So they have usually painful periods and they have this blood-filled cysts which are there all stuck to the uterus within. So not only is the uterus, but sometimes even the fallopian tube gets stuck. So although it is open, but it's not able to do its work. It's not able to move around. The mobility of the fallopian tube is lost because it gets stuck and adherent to the uterus. So we gently separate that out and make it back to doing its routine work. Very rarely, tuberculosis can affect the fallopian tube and they can get quite badly damaged. And in that cases, at least we can do a biopsy, confirm that this is tuberculosis and start an anti-tubercular treatment. That is the ATT treatment for the woman. So at least you're making a diagnosis, you're making the correct treatment started. Otherwise, there's no other way of figuring all these problems out. And lastly, when you come to the ovaries. Now, when you're seeing the ovaries, what happens is generally there would be a cyst or large ovarian cyst more than 5 to 6 centimeters size. It could be water filled, it could be blood filled. The ones which are blood filled are called as the hemorrhagic cysts or the endometriotic cysts, and they tend to get even stuck around the uterus. So they need to be separated, drained out. The cyst wall needs to be completely excised from within, and a new kind of ovary has to be reconstructed. Now, if there is a 45-year-old lady who's completed her family and has come to us with huge cysts, it's very easy job because we just do their clamp and remove the cyst and come out. But if you have a young 30-year-old lady, we do not want to damage her ovary. We have to preserve her fertility. We have to make sure her maximum ovarian tissue is preserved. Without damaging the ovary, we have to remove the cyst also completely. The surgery is a little more tricky because you are removing the cyst, you are removing the damaged part, but you have to retain the healthy tissue also within the body. And that's why we do the ovarian reconstruction procedure in them so that the healthy tissue remains back. So these are some, in brief, some of the minor procedures which we undertake for fertility. We'll take up the questions now from the chat box. You also need to understand that as of now, these kind of procedures are all daycare procedures. So you don't have to stay in the hospital for too long. If your insurance is requiring you to stay, you stay for 24 hours. Otherwise, even that's not required. Usually it's a walk-in procedure. Of course, it has to be done under general anesthesia. But since it is such a well finished procedure, usually you come in the morning of your procedure and by late afternoon, evening, you're back home. So the very quick procedures, unless you've had some major adhesiolysis or major myomectomy done, probably you would have to even then stay only for max 24 to 48 hours in the hospital. So generally, you recover well quickly after this procedure. The other thing you need to understand, which a lot of questions and queries come across for laparoscopy, is that then I'm going to need bed rest. So that's not there. There are not going to be any bed rest sought here. Second thing is that we are not looking at a gap. So if you have conceived, then that's good. And second is, if you're looking at conceiving, then we have to give it a little time, but it's not too much of a gap. So we generally do the procedure just immediate post periods. So we have enough time for recovery within that week, and we're just in time for your ovulation. And maybe if it's really good, then that same cycle or within the next cycle, you're heading for your pregnancy planning. There's no gap given. So that's good usually. Since the stitches are very tiny, there is hardly any pain, hardly any blood loss. And due to that quick recovery also, it is a preferred method over a laparotomy, that is a big cut, which could be given otherwise. So these advanced techniques are definitely helping the couples to come out of these problems a little quickly, recover faster, not lose on their working days, very important. And most important is that sometimes when a diagnosis is not made, you get a diagnosis. So what we call as an unexplained infertility. That's where also it has an important role to play. So hopefully this information is going to be useful to all of you. And if there are any queries, you can just put it in the chat box. I could help you out with the question and answers. And you can always mail to us. We are here available at the Apollo Cradle Hospital. I'm Dr. Nupur Sood. I'm an obstetrician, gynecologist, and a gynec laparoscopic surgeon. We have trained ourselves for these surgeries, and we have a very good backup team in our anesthesia and equipment wise to help us go through with these procedures smoothly here. I'm sure they're available in most of the cities. It's not something very out of reach these days. Very much available. Now, you should be unnecessarily also landing up in these procedures. That is one thing I also need to empathize on. Now, a lot of children and young kids and young girls who come to us with PCOD, which is a common gynec issue, that is polycystic ovarian syndrome. And generally the habit is to Google yourself and YouTube and check that, what is this condition and what's the treatment. So you need to understand that PCOD is a condition which requires medical treatment. That doesn't require surgery. Only when the couple is coming to us with infertility, with PCOD, even in that, they are not responding to the ovulation induction medications. That's the medications we give for conceiving purpose. Not responding even to injectables, which we give, which we call as poor responders, then is the time that probably we would consider going for polycystic ovary disease problem solving with PCO drilling. So drilling is nothing but it's just like it's a water filled with balloons. So we're giving 3 to 4 punctures on each of the ovaries, shrinking them back to normal size so that they start functioning a little better. But again, this is a bypass procedure. This is not the end of the game. From here, then we immediately tell them that now you should immediately try to conceive within the next 3 to 6 months. You shouldn't stop and imagine that that's done and no more further medication or treatment done. It is just a bypass step. You still have to take up your ovulation medications. You'll still have to continue with your good diet and exercise. And even if required, metformin would have been given to you for PCOD treatment. So this is just a bypass so that you start responding better. So PCOD, again, in those who are infertility also, not everyone needs a drilling procedure. It is kept as a last step and a back-end procedure. If nothing else is working, then we go for it for the couples. So this is something you need to understand. And don't get worried. There is always something to work on in this way. Science has gone a long way. We have very good fertility treatments these days available for couples to handle these conceiving issues. But you need to be a little more better informed. You need to be a little more logical when a treatment is given to you. And you need to understand. So it's just pure science. You look at it in that ways, then you would not have any trouble. If you are looking at it in the way that this particular procedure has been done, I don't have this trouble, this has been done, this has been suggested, so what is it I'm going to achieve by doing this procedure? This is something you need to sit and discuss with your specialist and then only go ahead with the procedure. So what you're aiming at should be very clear when you're undergoing a laparoscopy. See, when you're undergoing a laparoscopy, you know you have a huge fibroid. The message is very clear that just a laparoscopic myomectomy has to be done. So when you're having some conceiving issues, we have to make sure that is we're not just going in and doing one thing and coming out. We are making sure that the other things are also in toto. We are checking all the structures of the body which are going to help us conceive are functioning well, anatomically well, and they're going to not disturb the body from conceiving. So it's always a very in toto procedure which is done for fertility. And that's why it has been taken up as a special topic and discussed. If we have any questions, we can take in. Right, so we'll close up here, and hopefully this we can have this recording, and then whenever you want to go through it, you can, obviously being on the Facebook. And if there's anything, you can always reach to us at Apollo Cradle at Kormangla in Bangalore. And also, we are available to you on the Apollo app also 24/7, and as well as on the FB Live. So if there's any queries, we'll be happy to answer that back. Thank you everyone for joining in. We'll close the session here.